It's my great honor to co-chair with our NHI Vice President, Professor Xu, this section. So I would like to introduce our second speakers. It's IDDSI Chair, Peter Lan. So I will very briefly to introduce, maybe most of you will know the Peter. Peter was born in England, and he moved to Malaysia to have a very wonderful childhood with his grandmother in Malaysia. And then he moved to Canada and for more than 40 years. As you know, he is the chairperson of the IDDSI, it means the International Dysphagia and the Diet Standardization Initiative, as a chairman, and he already dedicated for more than a decade. So today he will give us a talk entitled with Improving the Safety and the Nutrition and Hydration Delivery with the IDDSI, the myths and the facts and the science. Please give a big hand to Peter.
Thank you very much for that kind and lovely introduction. I feel very privileged to be here with all of you today. And I really feel like, being a nutrition conference, to have a component about dysphagia and swallowing disorders, thank you for this opportunity to be able to tell you about our international initiative. So the name of our initiative is very long. It's International Dysphagia Diet Standardization Initiative. I don't think that you would like to hear me say that again and again and again. So for the purposes of this talk, if you will please allow me, I will use either IDDSI or IDDSI for short. Okay? 大家好，我的中文名就是叫蓝天林，英文是 Peter Lam。Yeah. 但是我的中文讲得不大好 so everybody please excuse me, the presentation will be in English, but if I happen to have my brain switch over and I start to speak 中文, the interpreters that are up in the top box there, please forgive me, okay? Yeah. So here are my disclosures. As a chairperson and CEO, I do, thankfully, the board awarded me a token honorarium because of my contributions. And then the conference travels and accommodation, thank you very much to the organizing committee for funding that. And I do have to tell you that as the International Dysphagia Diet Standardization Initiative, our funding actually comes from these amazing industry partners. But please understand that none of them, zero, have ever influenced the work of IDDSI or IDDSI. They believe in the work that we do, and so the information I'm going to present to you, hopefully you'll see, is quite unbiased of any industry influence. Okay? So typically when we think about swallowing, our concern is often this: aspiration. We know that aspiration events can possibly lead to pneumonia. We know that aspiration events can lead to hospitalization. Okay? The aspiration events, in some cases, lead to chronic coughing. And in the elderly population, when you're chronically coughing, it's very embarrassing. So you start to not want to drink, you start to not want to eat, and this is why it's so important for us to address eating and swallowing problems. And thanks to Dr. Keller, we saw that the screening tool that has been developed now actually has some questions around: do you have problems with chewing and do you have problems with swallowing? So let me just start at the very end, which is when we took on this initiative over a decade ago, we knew that we had to look at a globalized standard terminology to help improve patient safety. And I'll tell you about that information momentarily. We also recognize that we needed interprofessional collaboration, because if we don't have intercollaboration, then it's just another standard or just another framework. We needed that contribution from all these different stakeholders. And then we also knew that in order for research communities such as this to appreciate the work that's done, we had to harmonize the scientific evidence and best practice. So, spoiler alert, there it is. There's the international framework. You've probably seen it in some of the posters. Hopefully, this is not the first time you've seen it, but just in case it is, okay, you'll see that the International Dysphagia Diet Standardization Initiative framework consists of 2 sections. Okay? On the left-hand side of your screen are the foods and the terms for the modification of the food. And on the right-hand side of the screen, you see the terms for liquids or drinks and the modification of these drinks in order to help people that have swallowing challenges. Okay? The framework, when you first look at it and you go, gee, it's really colorful, it's lovely, it's like a rainbow. Okay? But keep in mind that there is actually scientific research even behind the colors. These colors weren't chosen randomly. They have been subjected to 23 different color blindness tests. And so even somebody with the worst condition of color blindness can still distinguish the colors. Each of the levels that you see here actually have 3 identifiers. 1, the term, 2, the number, and 3, the color. We knew we had to introduce these multi-methods for naming a texture level or a thickness level because it's confusing when you just use the name on its own. And when you look at number 3 and 4 and how they're interconnected, is one of the things that we found in our research is that the liquids of moderately thick and extreme thick actually behave very similar to their food counterpart of liquidized and pureed foods. So I will pause there for a minute, okay, and I will share with you myth number 1. Often what we hear is, oh, it's easy to talk about food, okay? Now, given that we're in a research environment, I thought we'd do a little bit of live research. Is that okay? Yeah? All right. So make sure that there's somebody sitting next to you, and if you don't have somebody next to you, will you just sort of scoot together or, go and turn around and say hello to people behind you? Okay? Yeah. Because I'd like to have you try something in an experiment, please. So the exercise is simply this. One person in your partnership, or 2 people if you're working in 3s, okay, we want one person to close their eyes. Trust me on this one, okay? Yeah, one person, close your eyes. The person with your eyes open, you're going to just describe this picture that I'm going to put up here momentarily, okay? Ready? Okay, close your eyes. Now, you can use English to describe this, 用中文, okay? 用 Hokkien 話, okay? Whatever you want to use. Okay, here we go. Describe to your partner what you see. Okay, the people with your eyes closed, 你可以看你的眼睛了，哈，你看看，他们跟你讲准不准？ For the non-English speakers or the non-Chinese dialect speakers, all I was saying was, did they describe it as the picture? Okay, so I think we've kind of proven ourselves here that describing food or talking about food is not easy. Now, did you use some of these terms? Did people use colors? Did people use, memories? Did people use potential smell? Okay, it's quite confusing when we're trying to describe food, but it's even more confusing when we're trying to describe texture-modified food, because half the time we don't know what it is. Okay, so just for the fun of it, I'll tell you that this is actually a tomato and cheese salad ground up. All right? Yeah. So, why didn't we use the same terminology? Well, guess what? When we first started this initiative over a decade ago, we went to look at what national standards were all around the world. We looked at the United States, we looked at Japan, we looked at Australia, we looked at Ireland, we looked at the UK, and scary enough, we came up with this mess. And you can see it is a mess because the terms are all over the place, okay? And that's for food. And then when we asked them about drinks, it looked a little better. But still, there were many different terms that were being used. This was quite a seminal study that was performed by Dr. Joanne Robbins and her group, and it's called Protocol 201. Those of you who practice in dysphagia and are about my vintage, okay, I was gonna say about my age, but then, it's kind of hard to gauge the age of somebody who's so far away on stage. And honestly, I don't want to age myself, right? But if you, were in dysphagia practice around that time when this was published, it was really quite earth-shattering when the claim was made where they said individuals on honey-thick liquids had poorer health outcomes than those with nectar-thick liquids. Now, funny enough, this was what they referred to as honey. So the term itself is misleading, and the conclusion was scary to a lot of people, but what most people don't do is they don't actually go and read the study. So they look at it and they go, oh my gosh, I'm not gonna give them honey-thick liquids anymore, okay? Here's another example for you. We always knew that the Brits and the Irish, they didn't really like each other very much, okay? But look at the way they name things. The same texture bee across the water is the exact opposite. We knew we had to go and survey health professionals and food services folks out there. And what we found is the fact that most commonly what people were using were 4 to 5 different levels of food textures. Now, interestingly enough, 16% of our respondents actually said to us, you know what, we use more than just the name. We use some kind of other scheme to actually identify that food texture. So it could be a color, it could be a number, some kind of a symbol, okay, because they knew that the name on its own wasn't good enough. And then with liquids, a little better, 3 to 4 different levels of liquid thickness, but 25% of our respondents said that they use another scheme. Here's the most shocking part of all. When we asked these people, how many of you actually check it before you serve it to someone? Okay, and these were food services, these were clinicians, we even had some carers respond to this. Look at that, only 40% actually checked it. Most people just put the food or put the drink in front of somebody without actually knowing what consistency it is. Okay, so it's based on all of that. Here we are, our first publication. It's open access. I know that the rule was don't take photographs, but this is open access. Scan the QR code, take a photograph, okay? It's also available on the IDDSI website. Please have a read. This is the reason why we did the work that we did in IDDSI. All right, let's go on to myth number 2, shall we? If you were trained around the time that I did my training, people with dysphagia were always told, thicken everything. The thicker, the better, okay? Because if it's thick, you can't possibly get it into your lungs. That's what we were told, right? Well, let me show you. Here are thick liquids. And I think some of you are sitting there trying to swallow rather hard right now. Thicker may not be better. When we conducted a systematic review, we found a few very surprising and shocking things. Okay? We did find evidence that thickening does help people. Okay? We know that. For those who aspirate, it slows down the flow. But look at the number 2 point here. Too thick. There is such a thing as too thick because residue accumulates and people will aspirate that after the fact. And what we have seen in evidence is that that thicker substance stays around much longer. They have tougher time clearing it. Okay? But we also found that there's no specific evidence that says to us, this is just thick enough, okay, or this is too thick, right? And so we do need some more work in that area. And any researchers here passionate about it, there you go. There's a topic for you to research on. Now, when it comes to food, sadly, there's not very much evidence out there, okay? All that we could find was the fact that solid foods, thicker substances require greater effort. That's the conclusion that could be drawn. And then ultimately, when it comes to texture modified and the use for treatment and management, it's really scary. There's very little literature out there. So, shall we move on to myth number 3? Okay, soft food is easy to eat. And I know that, one of the things that a lot of places in the world have been working on, particularly for the elderly population, because we feel if we soften the food, it should be easier for the elderly, because we do. We lose chewing strength. We lose oral coordination. Okay? Now, but what is the definition of soft? So let me show you an example of a diet order that was actually in an ambulance report. Okay, this ambulance driver was transporting an elderly lady back to her long-term care facility. He was kind enough and conscientious enough to actually look at the discharge papers, and this poor lady looked like she was starving. And so what he noticed was these terms. How many of you use this kind of a diet prescription? Okay, regular, pureed, regular. Well, this was his understanding, so he fed her. Makes sense, doesn't it? Regular bread, pureed filling, regular bread, right? And guess what? This is what happened. She choked and she died. Okay? Coroner reports, Australia, Canada, UK. Inconsistent terminology is dangerous. The word soft, unless it's well defined, is very challenging for a lot of people to understand. Okay? And, I don't want to be an alarmist, but when we search through coroner reports, it's ultimately sad. Look at all these different people, different ages. They choked on different foods, all perceived as soft. Okay? When we look at the physiological processes of us chewing, think about it today when you eat lunch. Okay? Now, I hope I don't turn you into a swallowing geek with this talk, but think about when you chew down food, okay, and you start to break it down into smaller and smaller pieces, and then think of the IDDSI framework, the left-hand side. That's what it actually is. It's how well can we break down the food, and all we're doing is using consistent terminology to try to make sure that people understand what that textural level is, what the characteristic of that food texture is, to best meet the abilities of the person eating that food. It's a very, very different way of thinking compared to our old style of, well, we've got this texture, and we'll feed you this because this seems to be most appropriate for you. What we're challenging you now to think about is, what are the person's abilities? And how can I best meet them at their abilities? Because we know that swallowing itself is the best form of therapy, best form of rehabilitation, the best way to help people maintain their swallowing function. So why give them something more modified than they need? Now, what makes us different? What makes IDDSI different than anything else we've ever done before? How many of you have done this before? You take a cup and you swirl it and you go, oh, you see how thick that is? Now, go home and make this. Okay? So we decided that that wasn't good enough. We need some way of being able to test the product. And so we came up with this thing called a flow test. All it costs us is one syringe, 10 milliliter syringe, 61.5 millimeters long. Okay, the dimensions make a huge difference. We pour the liquid into it, and then we let it flow for 10 seconds. And at the end of that 10 seconds, with this specially designed funnel that we've had to make, just because not all parts of the world are able to get this funnel, we can now tell how thick the liquid is. No more guessing. And the funnels, believe it or not, I'm very proud to say, are actually made in Taiwan. Okay? Yeah. And there's been a validation study that we've done on the IDDSI funnels to look at how well they compared to the 10 milliliters. Okay, so I'm doing a little bit of a used car salesman talk here. They come in packages of 10. If you wish to buy them, they're on the IDDSI website. Okay, no more sales talk. Right. All right, so let me talk to you about food for a little bit. You'll see that in each of the textural level, there's not only a descriptor, but there's also a testing method. We use very simple utensils like fork, like a spoon. We can even use chopsticks or fingers. Okay? When you go to our website and you take a look at the testing methods, you'll see that what we're concerned about is adhesiveness, cohesiveness, stickiness. Okay? Because I shared with you that myth. Thick isn't always good because thick can result in residue. So the testing method are meant for us to determine, is it easy enough for it to pass through the oropharynx without it creating a lot of residue? As we move up in textural levels, we also want to make sure that the food is actually broken down enough for those with chewing compromises. What we found is that 4 millimeter particle sizes for adults, when it's moistened, actually triggers the brain to say, it's safe, it's okay, swallow it. Okay? And then for pediatrics, it's 2 millimeter particle sizes, but it has to have the appropriate moisture content. And then when we move up to the next size here, we wanted to make sure that we look at choking risk. So those of you who work in emergency medicine or have had ever to put a trach in somebody, okay, many of us, we select the trach sizes by looking at the person's thumbnail, okay? And so if you're looking at the thumbnail, that's about the same diameter as the trachea. So if we made particles of food smaller than the person's thumbnail, which on an average is about 15 millimeters for adults and 8 millimeters for pediatrics, then we know that even if that food goes in the wrong way, it's at least going to fall through, okay? But there was a second dimension to that, and that is, how do you determine softness? And there is a science behind this. Dr. Katrina Steele in her lab did some work on tongue pressures. And what she found was that the average tongue pressure from tongue to palate, okay, is anywhere between 15 to 20 kilopascals. Now, we just happen to be designed with this wonderful thing called orthostatic pressure of our thumbnail or our fingernail. When you press it down to the point where it just turns white, everybody give that a try, okay? We're actually generating about 17 kilopascals of pressure. So if we use that as the tester and we press down on a food and it deforms on a fork, like you see there in a fork pressure test, we know that the food is soft enough. Okay, let's move on to myth number 4, which is IDDSI is based on expert opinion. Well, I can tell you that there's a lot of work that went through following all these different processes for qualitative and quantitative studies, okay? We combine the national standards outcome, we combine the stakeholder consultations, there's systematic review that's done. We involved over 10,000 non-duplicate articles undergoing relevancy review, quality rating checks, and the synthesis from 36 quality articles that were actually produced by this wonderful group of people here who are experts around the world, but they screen through the evidence in order to produce this particular article. And once again, it's accessible to you on the website. So what has happened since? We know there are over 3,000 articles now using IDDSI. It comes from a diverse area of studies, okay? It's now ventured into liquid medicines because we need to know how thick some of the liquid medications are. We've actually used it to measure the thickness of barium because that's one of the diagnostic tools is by using barium liquids in order to check thickness or the swallow function, okay? We know we've got studies now looking at the validity of measuring thicknesses. And then, surprisingly, for those of you who work with tube feed formulas and this trending towards home blenderized tube feeds, we now can use the IDDSI flow test to check the thickness. We're validating with testing methods, instrumental testing methods. There are even now studies looking at the printing of 3D foods. IDDSI has now influenced culinary studies, okay? International adoptions. We have Israel, we have France, we have Singapore now mandating and legislating IDDSI as the standard of choice, okay? And so finally, let me just get to the most fun part here. And this is the truth or the myth. Because so often we hear modified diets increase the risk of dehydration or malnutrition. And that's what we often have understood. Well, look at this. What a lovely menu, right? And then you get this. Would that ever lead to decreased appetite, Dr. Barreto? Maybe, right? Yeah. Okay? Yeah. So this is an experience my grandmother had. Okay? My aunties were all schooled in Catholic schools. So they thought, oh, let's bring grandma to a Catholic hospital because that's where she'll get the best care. Well, grandma's grown up all her life eating Chinese food, but she was served this. And then we overheard her talking to a Mandarin-speaking nurse. So she said, 我吃屎了, 我吃屎了, okay? But what she meant to say was, 我吃屎啊, okay? So, what she may have been better served might have been something that is more culturally appropriate for her. But even when you look at the two different kanjis in front of you, they're very different in characteristics. One is more liquidy, has more water separation, and that may cause somebody to actually prematurely aspirate the liquids, whereas the other one's more cohesive, and it may be actually easier to manage and swallow, okay? We've now got studies that now show hydration is not so much an influence of the thickness, it's how we get the drinks to them, okay? Do we really need to use thickened drinks? That's now being challenged. With IDDSI, what we're starting to see is a trend of bringing the thickness level down. And what's amazing is there are now studies that show slightly thick level is sometimes all we need, particularly in elderly care, okay? With texture-modified foods, what we're starting to see is when people start to use testing methods, they're producing foods that are more consistent. And you're no longer giving people food that's overly modified, overly sticky, that causes them to have a difficult time. Okay, so when I was a kid, I watched this cartoon. Some of you may remember the Jetsons, right? And they had this wonderful machine where you could just punch a button and the food came out, okay? Now, I wish we could do that now, particularly if there was a machine that could make IDDSI texture foods from real food, right? When it comes to dysphagia management, it's a real balancing act. So here, let's end at the very beginning. How do we improve nutrition and hydration with IDDSI? Well, I challenge all of you to think about the consistency and the terminology that's used. Because if we can use consistent terminology and we can learn from each other, we can gather data that we can compare across the board, well, maybe at that point, we can actually produce something that we can measure more consistency in terms of intake, hydration, overall health, okay? Please go to our website for more information. There are translations available, lots of different materials available to you. If you want, come and visit us in our next Asia conference, just a few days away in Kuala Lumpur. I know some people in the audience are coming. And then next year, we're actually going to Florence, so come there as well, okay? So when it comes to IDDSI, let's just say that with IDDSI, let's get away from the fact that it's a prescription. It really is meant to be a standard that is a standard term, testing method, okay, and the characteristics about the food. The purpose of why we do this is about improving safety. It's a global initiative. It involves all of us. May I invite you, this audience in Taiwan, in Japan, all over the world, let's all head towards the standard so that we can help improve safety for the people that we care for. Thank you very much.
Thank you so much. Thank you, Peter, for your comprehensive, informative, and nutrition layman friendly talk. I think most of we have many questions, but we have the QA section in the end of the section. So let's move on to the third part of the section.